Hello, welcome. Thank you for joining the Pennsylvania Medical Home for the first of a three-part QI series. Before I turn it over to Dr. Turchi, I'd like to take this time to remind you, Iris will be muting all lines. During this presentation, you are welcome to type your questions in the Q&A pod. For the folks that are on the phone, there will be time for questions and answers after the presentation concludes. At that time, I will remind folks how to unmute their lines by hitting #6. I will now turn the webinar over to our moderator, Dr. Renee Turchi.
Thank you, Eileen. Good afternoon, everyone, and thank you for being here with us today. I'd like to introduce our speakers for today and like to thank Eileen and the staff of Medical Home AAP for all the work in getting this QI series going. We're very excited about this at Pennsylvania Medical Home Initiative and the chapter at the AAP, so we're thrilled you're here with us today as part of this journey. So our first speaker today is Amy Wishner, who is the Program Director of the EPIC Pediatric Obesity Prevention Program and the EPIC PA Immunization Education Program. Amy has more than 25 years experience in public health and nonprofit settings, including 15 years in management. Amy has been recognized for outstanding leadership, detecting emerging trends, incorporating new research and best practices, working collaboratively and fostering teamwork, utilizing communication modalities best suited to audience needs, and managing resources efficiently and creatively. Amy has worked in both an urban large city, Philadelphia Health Department, and as director of several statewide child health programs incorporating research, application of best practices to real-world settings, and advocacy. Thanks, Amy, for being here with us. Also with us today is Dr. Sue Cressley, who is a general pediatrician and founding partner of Cressley Pediatrics in Warrington, Pennsylvania. Her interest in combining technology, high-quality pediatric medical care, and business leadership has been instrumental in the practice's NCQA PCMH Level 3 recognition and their continual ability to thrive in today's challenging healthcare market. Cressley Pediatrics was the recipient of the 2017 HIMSS Ambulatory Davies Award. Sue is the immediate past president of the PA chapter of the American Academy of Pediatrics and is the former chair of Pennsylvania's Pediatric Council. She is currently the SOPM, Section on Administration and Practice Management Representative to the National Academy's Private Payer Advocacy Advisory Committee. Sue is very involved in the adoption of HIT and dedicated to promoting pediatric functionality to support pediatricians, their patients, and the practice of pediatrics. She's been involved in multiple HIT initiatives in Pennsylvania and at the national level and currently is on the Pediatric Advisory Committee for the Child Health Informatics Center at the Academy. Dr. Cressley is a strong believer in using data to improve quality of pediatric care and to promote adequate payment. She is also active in the QUIN and ePROS networks as well as the Council on Quality Improvement and Safety. In addition, Sue is part of the Task Force on Pediatric Practice Change and is member of the section on telehealth care. She has given multiple presentations on the changing face of pediatric practice, including population health, alternative payment models, and team-based care. Sue believes that all children deserve access to a well-coordinated pediatric-centered medical home and that all pediatricians deserve the resources and support to transform their practices to meet their patients' needs in constantly changing healthcare environments. We're delighted to have Ms. Amy Wishner and Dr. Sue Cressley present on this timely and important topic. Amy, please start the presentation. Thank you.
Hi, good afternoon, everyone. I'm delighted to be here, and I think our experience with our chapter-wide quality improvement project will be helpful to you in thinking about moving forward with your project. So our project was quality improvement around improving human papillomavirus, HPV, administration, series initiation and completion. The lead physician on it was Dr. Danielle Kasher and myself, and Samantha Webster from the chapter staffed it. The learning objectives for today are to articulate the important implications of quality improvement for your individual practice, to discuss the impact of people, processes, and technology on your quality improvement efforts, apply quality improvement principles to specific projects in your individual practice, and to become empowered to use quality improvement to improve patient care satisfaction, both for the families and the practice team and for payment. So the AAP HPV Quality Improvement Project was a national project, so all the states participated. But the other chapters had only the AAP funding, and up to 3 sites were unable to provide a stipend, and everyone else but us used the equip. Now, the Pennsylvania chapter, we were able to secure some additional funding from the Pennsylvania Department of Health Cancer Unit, and so we had 33 practices across the state. We were able to give a stipend of $1,500 per site, and we used the KETA database. So this program ran, with some pre-planning, but the program itself ran from January through September of this year, and it included 3 webinars. One, much like this, at sort of the outset, here's what you need to know, here's what you need to do. 7 data pulls, so that was a baseline plus 6, and each of those data pulls was for 10 charts, and for our purposes, it was 10 to 11-year-olds, the first 10 to 11-year-olds that walked into your office that month for any reason who had no contraindications to HPV immunization. So, it sort of, it depends completely on how you define your patient population. One thing I'll mention about that relatively small number of charts, because this kept coming up, it's a relatively small number of charts. It's not giving you a true rate of anything at your practice, although they do find from studies that it's quite representative of what your true rate would be. And secondly, by doing a small chart pull and looking in detail at these specific charts and what happened with these patients, it points to specific small tests of change that you can use for your Plan, Do, Study, Act, or PDSA cycles. So the process of pulling the charts and then the people participating in the QI team, reviewing them, seeing what's happening about your topic of interest, and coming up with specific, small, doable tests of change, implementing that, and then in a month pulling a second set of charts and doing that for each subsequent month, and assessing that in this constant process. I mean, this is the part of quality improvement, and I'll be talking a little bit about what some of the other parts of quality improvement are. So we went through, for our purposes, 6 PDSA cycles. And Dr. Cressley was really instrumental in helping us recruit practices, and we really, really appreciated that. We also were able to tap into 2 district-wide AAP meetings, which were at the start and close of the project, where we were sort of all oriented to what was happening. The chapters discussed the projects, and we had a quality improvement expert who discussed the reliability, sustainability, and spread, which were key to really maintaining quality improvement. So this was our 33 sites, and we focused on independent practices, feeling that these practices both could benefit from the support we could offer and also would perhaps have more flexibility to implement change and do this project. We had a pretty short timeline. I'm going to run through the types of data that we got. Now, this is looking at the project as a whole. Now, each individual practice, and this is for the whole time period, each individual practice on a monthly basis would see their data point and plus the data point for the group as a whole. So they'd always be seeing, in a sense, how are we doing better or worse, and it might make people either seek additional input, resources, et cetera, or conversely, we could see, okay, these people seem to really know what they're doing. Let me call them and see, you look like you're doing really well with this. What do you have to share with the rest of us? So, that first one was HPV initiation. This is looking at completion. We looked, for our purposes, and again, it depends how you define your variables, but we were interested at the outset in leaving open the possibility of gender differences. There are a variety of reasons for that you probably are aware of, but I'm just saying, so at the outset, we were wanting data on female and male vaccination initiation and completion, and then, interested, and those were also potential areas for PDSA cycles, intervening with one gender or the other. So male HPV vaccination initiation, female HPV vaccination completion, and male HPV vaccination completion. I'm going to mention just a couple of things, of the types of things that practices shared that were helpful. One is in talking about HPV as cancer prevention. One site in particular just shared that they used the term of preventing cancer in your man parts, and that was helpful. We talked about sharing information about that you immunize your own children. The idea of sandwiching HPV vaccination in the middle of the list of things due at that adolescent visit rather than either listing it first or last, either of which would tend to raise the alert more. And this is part of the CDC recommendations, so we definitely took advantage of the CDC resources. This Keep Calm and Standardized, there was a lot that we did around making things the way we do things, and at this visit, this is the routine. This is what we all follow, and the idea of culture change at the practice was really important. And for our purposes, having that you would have to opt out rather than opt in to this vaccination. We talked about the idea that at sick visits, this was interesting because in a way at the outset this was something that we had expected that people would already be doing, that immunizing at sick visits if no contraindication, but it turned out not to be the case, and so this was something that many practices made a culture change, an EHR change in their practices to accommodate the time, the staff, the reminders, etc., so that at sick visits where there was no contraindication they could carry out our our project, and that could be, part of their PDSA cycles. Doing outreach through social media, through email blasts to bring people in. In our particular project, and again, I'm just mentioning this to get to the point about that it depends how you define things and what you're trying to accomplish. As I said, we were pulling charts of people who were in the office already. So our particular program did not look at trying to get people in who weren't showing up at all. Not that that couldn't be a PDSA intervention, but that would go more to that idea of what is the true rate of everybody eligible who's in your patient group. And of course, if people refused, making sure they were aware and using the AAP refusal to vaccinate form. Offering the vaccine at younger ages, and again, this was a culture change at the office, getting everyone on board and aware of all levels of staff with that, if you start the vaccine before 15 years, you only need 2 doses, and not only is it only 2 doses, but you have better immunity the younger you get it, there's less association with sex. And then some practices shared something that was useful, and other practices picked it up, which is that even before the vaccine was due, they would prep people by the year ahead saying, okay, at your next visit you'll be getting these vaccines, here are the vaccine information statements. And also, this vaccine, even though recommended at 11 to 12, can be given as young as 9 years of age. So again, making people aware of that recommendation, and given what else is due at different visits, some practices decided to be giving it at younger ages. As I mentioned, we also left room for gender-specific interventions. So again, I think it's really important at the outset how you set things up, because as you know, if you're not set up to collect data or allow interventions, it's hard to tack it on at a later point. So our aim was really, as you can see from this picture, to have participants teach each other. We really wanted the multidisciplinary involvement leading to culture change. And, this was our goal: improve population health, satisfied providers, reduce care costs, with hopefully satisfied patients in the middle. Some people also shared a lot of tools that worked at other sites. One thing that was really of interest, the idea of the cancer bundle, one practice shared, that they included sunscreen, smoking and tobacco prevention, use prevention, and HPV as part of their cancer prevention bundle. So that was kind of interesting, not something we had thought of. The various practices made short webinars for YouTube for use in their patients. One practice did a very effective one that was simply of everybody at their practice, all levels of staff, just saying, I immunized my children with HPV vaccine, just that, person after person. And the bike helmet analogy, you use a bike helmet before you get on a bicycle. Some of the quality improvement lessons that I think would have been good for us to have been more aware of at the beginning, and was sort of picked up as we who worked on the project became more educated, where not just that we needed to achieve the goals that you set up for your MOC Part 4 credits and for your quality improvement project, but the whole idea of reliability, maintaining these results over at least 6 months, sustainability, and spreading the lessons you learn to other parts of the practice. And as I said, with reliability, that just vigilance and hard work isn't enough. Any way you can standardize what you're trying to achieve, whether it's in your EHR, order sets, standing orders, etc., will be really helpful. However much you can build in decision aids, reminders, and always asking the people who are providing the care or providing the reminders what works for them. And of course, family engagement. Sustainability, the more people that are involved, the better ownership there is. And, staff training and education turned out to be a very important part of our program. And continuing to measure, perhaps with fewer measures than you have with your quality improvement, in order to sustain, for 6 months or longer. And so that may be something that you're not thinking of when you're starting your QI project. And of course, ensuring support from all levels of leadership. We hope to, obviously you hope that what you're doing, you're seeing an advantage over what you were doing previously, that it's compatible with, the way you're used to working and, how your practice works and patient and family experience, with the complexity of what you're trying to achieve, and with the plan, do, study, act cycles, picking very doable, achievable, small tests of change that have to be, observable, measurable, etc. We did ask these questions, and I think you might want to think about this type of thing for your work as well, is asking about the general effect on your practice's workflow, either positive or negative. And as I said, we left room for something we weren't sure we would see, whether there were specific differences in the males and females in terms of what people decided to do, so we wanted to ask about that. And this last point, did the project affect the whole practice, or was it limited to only those going for the MOC? And I have to say, from my point of view, unfortunately, there were several practices where really people said, it was just a couple of people doing the MOC and the rest of the practice wasn't involved. And I think, the more you can be, setting that up at the outset to have the whole practice involved, or doing some kind of education along the way to try and enlist the support of the practice, the more the real goals of MOC, of quality improvement for the whole practice, will really be achieved. We provided a lot of resources. I'm sure you will too. There's lots of stuff available, so just mentioning that. And the way that we, the feedback we got about having this series of webinars, people really liked it. The organization, the educational materials were very much used. People want educational materials. People really found KETA very easy to use and good. And the timing seemed to work well. The time we had and this monthly chart pulls, that all seemed to work pretty well. We hope, obviously today we're part of spreading the lessons to PAAP, and we're trying to do that through the e-news as well, both about HPV immunization in particular, quality improvement in general. We did apply for one other grant, which unfortunately we didn't get, but there's other opportunities for grant funding to try and do the work that I'm talking about sustaining the quality improvement, other immunization works, and other quality improvement, which of course this is. And just to be thinking about how spread works in terms of innovators, early adopters, early majority, late majority, and traditionalists, maybe just sort of file that away in your own thinking about this. So thank you very much. Here's my contact information. If I can be of any further help, I'd be happy to do so, although I'm leaving you in very good hands with Eileen Thompson and Dr. Susan Cressley. So Dr. Cressley, please go ahead.
Thanks so much, Amy, for that really helpful presentation. So I'm here to be your TED Talk champion and get you all psyched to roll up your sleeves and do some hard but very rewarding and valuable work. Next slide, please. So let's talk about what quality improvement really does and what quality is. And it's really the correlation between things that you do to deliver health services that impact positively a desired outcome of individuals, your families, and your populations. So it actually means that you do something in your practice that correlates to some positive outcome for the patients and your community. The bad news is that this is never work that's ever done, because there's always room for improvement. A key metric is that you can't improve what you don't know. And I will tell you, years ago when I embarked on quality improvement in my practice, there was a lot of hesitancy because we all absolutely knew in our hearts we were giving awesome care and how much could we really improve. But what really happens is when you start to measure what you're doing, and that's now infinitely easier, but not completely easy overall to do with our electronic systems. You have to measure what you're doing to actually see how you're performing and make sure that you don't have a false sense of your performance level. Sometimes that's disconcerting, but I don't want anyone to get discouraged. You measure it, you know where you are, and then you have power to improve it because you know where you're starting. Next slide, please. So who cares about quality improvement? Well, there are a lot of people in the outside world that have a lot to do with us getting paid and getting rewarded and getting maintenance of certification who care about QI. But the most important thing that I want you to take away from this slide is that none of those people can do QI without us. It is the practice delivering care, making those decisions at the point of care that affects what happens on the other side. So quality improvement can't happen without our practices. Now I'm going to take that one step further, and quality improvement in your practice can't happen without everyone on board. So as Amy alluded to, this can't just be a couple of people who decide it's a good idea. You need to inculcate this, let it go all the way down and all the way back up in your practice so that everybody's on board. So how does pay for performance, and let's talk about this, and one of the reasons we're talking about pay for performance is one of the ways that you can get enough money and resources to do this important work in your practice is if you improve, there are monetary rewards for doing good quality improvement work and having measurable differences. So for many of us across the state, there are direct incentive payments for improved quality, and often it's in comparison to peers, but for some payers, it's just getting better yourself. And so I don't know about your practice, but in my practice, I get bundled checks every year from my major payers because I am a rock star in quality performance. It's also led to higher payments in some of my capitated plans because I am so good at this, and you can be too, that if you are good quality care, the insurance company wants to reward you in some way to incent you to continue your work and to incent other practices to rise to high quality performance. You can actually get additional per member per month dollars throughout the year in your capitated plans. And in some places, practices, independent small practices, you don't have to be a big practice to make this happen, can get higher fee schedules or bonus percentages if they are a star performer. So we're also starting to see across the state that there are preferential networks that some payers are now excluding poor performers. And I will tell you that some of the hospital systems across that are self-insuring their hospital employees are starting to take some of the poor performers of quality and starting to carve you out of ability to even see those patients. So if you think this important work doesn't apply to you because you're not getting bonuses, I would caution you that you still want to do this important work so you don't start getting carved out of being able to take care of certain patients. And we are in many places in the state starting to have tiered copays. And if you're a practice that's a star quality performer, you may find that your patients actually have to pay less to see you than a poor performer, and it is incentivizing the patients to be attracted and move to start performing high quality practice. So some of us are seeing all of these things happen in our regions, That's not happening everywhere, but it is starting to spread, and so that's why this is important to every practice, so that you are well positioned to be a good, high-quality practice, so you position yourself to thrive in the changing healthcare market. Next slide, please. A little bit about the difference between quality improvement and quality measures. So there's a lot of stuff that happens in reporting for meaningful use and PCMH and other things where they are measuring your performance. And that measurement, as I said early on, is key to understanding where you are, but that's not the whole story. That's just the beginning. You need to take that measurement and then figure out why you are performing well or why you are not performing well, and then use the quality improvement, the true QI, so that we can work to continually improve. Now, this requires that you actually think of your office as a health system, right? There are interwoven parts. You have to say, what happens for the patients who don't come to the office? What happens when the nurses talk to people on the phone? What happens when people, bring in a form to be signed? You have to start talking about the whole system in your office and how patients move through and around your practice. And then you need to use your improvement so that you're targeting how this affects all the systems within your practice. This requires commitment. It's not for the light of heart, but I would argue that if we are going to give good care to our patients and make ourselves sustainable, we need to make sure that this is ingrained in our practices, and this whole project is here to get us all excited and make this start to happen. Next slide, please. Okay, so what do you need to be successful? And I'm absolutely sure you're all going to be successful. Some of you more than others, but there will be success across the board. The first thing you absolutely need to do is have a devoted quality improvement team to lead the projects we're going to talk about. That means that it's not everyone standing around after this webinar saying, well, I don't know who's going to do it, let's talk about it next year. It means that you decide at some point that you really have to work at this. Then you need to have practice buy-in. Because you on the call are excited about this doesn't mean that your partner who's close to retirement, or the new doc who just had a new baby, or your front desk staff who really doesn't think you need to change the way you do anything. You can't do this and sustain it without having practice buy-in. So somehow we would love to help your team decide why this is important and get buy-in, but you're going to have to figure out what might work for your particular practice. In addition, you have to have protected time to do this work. You can't take an already overworked staff who's answering the phone and giving shots in room 2 and calling up the mother for tomorrow's appointment to also be doing this QI work. In my practice, the QI team has a couple hours dedicated in the back room where the phones are not ringing, so that they can thoughtfully work on projects. You're going to need an ability to pull reports, and if you're not the techno guru in your office, you need to identify who that person is, because Amy's process really worked on just a small chart review. We're really going to move this up to try to get better data aggregated, so you know really and have a bigger picture of what's happening in your practice. That's how the quality metrics work that many of you are already using to report for MU and other projects. And we're going to need some data mining and data reporting, which will be some challenge for some practices, but there should be at least some ability to pull information. Lastly, you need a willingness to change. Every practice has someone who always answered every question but we've always done it this way. You need to make sure that gets parked in the parking lot and doesn't come in the room. We have to be willing to always look at this in a new way, learn, grow, and change. And one of the ways I've always sold this to my practice is we don't expect our parents and our young families to interact the same with us in the newborn year when they have a lot of problems and a lot of different questions relating to feeding and development. We expect them to grow and develop into preschool and school age and teenage, and they have different needs from us at those different stages. We have to think of our practice as a continually developing continuum, and we're moving along that process and changing accordingly. So the QI team ideally should have a provider lead. If you have a PA or an NP who's really embracing this and is well respected in your practice, that can be that person. But pediatricians are always awesome leaders of a team, and I would encourage you to find one. But they should not do this work alone. There should be another non-provider lead. It may be an office manager or front desk staff or a recall coordinator or someone else in your practice. You want to include clinical staff members, your nursing staff. You need to have scheduling staff in here because a lot of the work we're going to talk about requires appointments. So somebody in your office who actually makes appointments and schedules appointments is going to have to be part of the team. And again, you need to have protected time. Next slide, please. So what are our expectations from everyone who's doing this work with us? You're going to have to attend webinars. They will be recorded for the off time that somebody's got a kid event or a vacation planned. But we do expect that the QI team leads will attend webinars. There will be work in between webinars. This is not going to be just passive interactions. We're going to give you work to do. And so you should plan that you're going to have some work to do in between the webinars. You're going to be completing some survey monkeys in between so that we can get to the next steps and drive how we can best help you along the process. There will be an in-person boot camp meeting where you will be expected to roll up your sleeves and really get to work. And you're going to need to know how to pull your reports from your EHR system to support the measures. And we will get to that a little bit more in depth as we move through. The two projects we picked are improving adolescent well visit rates and improving adolescent immunization rates. And while Amy's project really focused on HPV, we want this to be about Tdap, meningococcal, and HPV. The reasons we picked these two projects are multi. They are something that a lot of practices struggle with. A lot of times engaging families in the newborn and early childhood and get ready for school is easier. We start to lose our engagement of our patients when they become adolescents. It is also things that our payers struggle with, and they are really hoping to sort of see improvement in that area, and we may be able to get resources from them. And most certainly, they are in most of the pay-for-performance metrics. And if we can help each other improve in these arenas, the return on investment should be there so that you should get increased payment to continue to do the work. Even if you think about it, you're getting paid to do the well visit itself. So if you recall the number of patients getting adolescent well visits without even bonus payment, you should see return on investment in the bottom line of your practice, and that will be able to fund you to continue and sustain this important work. Next slide, please. Okay, the adolescent well visit rates we know is a challenge for many practices. It aligns with the payer goals. It's going to be important for you to figure out what is your baseline rate. And we understand that this is not going to be exactly the same for all of our practices, but we're looking for you to understand where you can get this information and how you can measure your progress. So you may get baseline performance rates from your payer. You should be able to calculate something from a practice management or EHR system. We want you to be able to measure this and track it over time. And so it's going to be important that you at least investigate what's possible in your world so that you have data that you can measure continually and work to improve. Next slide, please. So this is the HEDIS measure. This is what the payers have to report to NCQA. Some of you may not know this, but the payers actually have to report how they're doing for their insured. One of the things they have to report, and they are compared to other payers, head-to-head, Medicaid, and private payers, is how they are doing with adolescent well visit care rates. And that is how HEDIS defines it, and the link which you'll get in your slides will take you out to where it is. It is defined as the percentage of enrolled members 12 to 21 who had at least one well visit with a primary care person during that measurement year. So this should be an annual well visit for your patients who are 12 and older. Next slide, please. The adolescent immunization rates, as I alluded to, is both Tdap and Menactra, and then HPV. In prior iterations of HEDIS, these were broken out. You may not all have the same query. Some EHRs may be able to give it to you as a lump or individually, but again, you're going to want to know where you can get this data and how you can keep pulling the information to track it over time. Next slide, please. This is the HEDIS measure that has been posted for this year, and this is at 13. Notice the denominators matter. The adolescent well visit is 12. This is 13. Who had one dose of meningococcal, one Tdap by their 13th birthday. So here's what you have to understand about HEDIS. If you're catching these kids when they're 14 because you didn't see them before they were 13, they will never meet this measure. It is still important to capture them, and you may measure that in a different way. But when HEDIS is measuring your performance, you might say, that patient had that Tdap, or that patient had their Menactra. But you look back and they had it when they were 13 years and 1 day old, they fall out of this metric. So the more we work on this early on, the better we can get our performance over time. But you'll notice when we initially do QI work, you're going to be picking up patients who were left out for the last several of years. That's still good care, and that's still good quality improvement. Next slide, please. This is the combination vaccine. There was a different HPV vaccine. They have now rolled it up this year into this definition, which is HPV completed by age 13, as well as the other metrics. Next slide, please. Okay, so here are some ways that you need to start thinking about this so we can start our important work. One of the things should be, you should be asking, what do we think our biggest gap in care here is? Is it our 11 and 12-year-olds for Menactra? Is it our HPVs? Is it are we getting the 5th and 6th graders well visits for adolescents because they need the school form, but it's our 13 and 14-year-olds? Start asking yourself, what's our biggest gap? And then what's going to be our biggest challenge to addressing those gaps? There are people, processes, and technology that are needed to make yourself succeed at this. Is it going to be pulling charts? Is it going to be the patients that we don't know because the payer says that there are patients but we don't even know how to get in touch with them? Is your biggest challenge going to be that you don't have enough room in your schedule to fit in well visits? Is your biggest challenge going to be that your front desk really doesn't believe HPV vaccine is important? You're going to have to ask yourself and ask questions of your whole practice team so that you can start to really look at what are those challenges going to be, and then you will not be able to do all these. Amy really alluded to picking a small project. You're going to have to prioritize. But remember, the good part about this is the work is never done, which is also the bad part. But if we're really inculcating this into your practice, you're just going to be like, all right, we're owning this, we're better at this, now where are we going next? Because we already got this as part of what we do. You're going to need people, processes, and technology, and I would like to ask yourselves, as a team, shortly after this webinar, what do we need to have in place? What are we going to need to be successful? And how are we going to make that happen? Next slide.
Okay, now we're going to
go for it.
This is Renee. Thank you, Dr. Cressley, for that wonderful presentation, and thank you, Amy, as well. At this time, we wanted to open up our presentation for questions. I think we were given a lot of useful information, so you can type your questions in the question and answer box right on the webinar, or if you prefer to use the phone, you can hit pound key and number 6 to unmute your line. We're happy to take any questions at this time.
For anybody using the phone, you have to hit pound 6.
Okay. Amy, this is Renee. I have a question for you. We're waiting for folks to tee up. So you did have MOC, and one of the things that you said that was interesting to me that I think is, you know, I guess it sort of makes sense. I'm sort of thinking, you know, I hadn't really thought about it this way with MOC for a lot of us, because within a practice, everyone sort of comes up at a different time. So in some ways you could, as I was listening to your comment about how for some folks, it sounded like what you were saying was some of the folks that were engaged in this project that were getting MOC credit kind of did it and did all the work, but the spread didn't occur through the practice. So I think that raises a really interesting issue, because you could almost see the other side where in a practice you could be like a total nerd and have like every one of you do a different MOC project to actually increase the bandwidth of QI you're doing. So do you feel like when you're thinking about, because we're, you know, thinking about MOC for this project, that's something it sounds like at the gate, what I was gleaning from what you were saying is that if you could do it over again, you would, in addition to the QI team, have some of the physicians sort of enlist or have spread be occurring more from the get-go? Is that kind of what you were going after there?
Well, you know, we were aware of this. I mean, the you know, the optimum is for the whole practice to be involved, and I think Dr. Kressley did a great job of saying, okay, for a specific project, the point about having a non-physician co-lead, and also for what you're doing, the importance of having a scheduling person involved. I mean, we were aware of that, but I think we weren't thinking enough at the outset that that might not be the reality. We were, in a way, we were sort of just assuming, oh yeah, everybody at the practice will be involved. And I think having that awareness that actually, which it sounds like you already have, that it may, the people who are actually getting the MOC Part 4 credits, they may be, you know, everyone may not be involved. And just to have that awareness, and so maybe along the way be asking about that, providing support for ways to be involving everyone, to keep on asking about that, how much is the whole practice involved. I think that's more the point.
Great. And MOC was the practices found it useful that you were offering MOC credit?
Oh yeah. That was a huge, huge draw. Absolutely. That plus the stipend in our case was you know, for some of the things that you were saying, Dr. Kressley, that, you know, people in general feel like they're extremely busy, they are providing good quality care, and so, you know, until you start measuring and really thinking about the issue in more depth, you may not be aware of, you know, yes, we can improve.
So let
I know
me tag
some
on to
other
that.
sites also have done some kind of low-key and friendly competition. I mean, Dr. Tricia Pill, when she was at the CCP practices, had a fantastic quality improvement initiative where they did share the rates of individual physicians and then practices, and sort of comparing physicians and practices with some sort of good-natured prizes for those who did really well or improved a lot. So, you know, I think there are a lot of kinds of things depending on your situation and what feels like will work for your site. But I guess I would just have your eyes open to the fact that you need to keep asking about and sort of monitoring how much the whole practice is really involved, and to have that as maybe sort of one of your subtexts, one of your goals that's sort of implicit in the work you're doing. How can we be keeping on involving people and bringing people in? Because, you know, not everybody at the outset is going to jump onto this.
So Renee, if I can tag team onto this, the other thing that I think is really important is, and again, if you can stratify this in some way by how people are performing, I think you have to give them an incentive and a win. Why are we doing this, right? Some of it is to give care, but some people there will be an important piece to the people who aren't on board to find out what the barrier is. Why are you not on board? Do you think it's not important? Do you not understand what we're trying to do? Do you not believe the data? And in order to there may be different motivating factors for a lot of people. There's a practice that I helped do a well visit improvement project where we actually figured out if each doctor did X amount of additional teen well visits, the additional income it could add to the practice. And then they started to think about, okay, maybe I'll turn that sick into a well, or okay, maybe I'll start earlier and add a before school well visit, because if your providers are not coin operated, as they say, or that doesn't apply to staff. What we also did was said to staff, you guys have been begging us for a X, care coordinator, whatever. If we can add our well visit rates to this, that's enough money to hire a full-time care coordinator to do this work. So are we all on board? So you have to figure out what the motivator is and if there's a barrier, work to remove it.
Okay, I think we have a question. Read the question. We don't have. Yeah. Denise, did you have a question?
Yeah, we did. This is Scott Tyson from Pediatric South. We were just reading through some of the stuff, and I don't know if anybody can comment on that, but we were amazed that Rhode Island had such a high rate of HPV immunization for both boys and girls. Could you comment if anybody knows any reason for that, or any tips that they may have been sharing with other states?
Hi, this is Amy. I mean, one thing I know is related to this is the fact that they're a tiny state with not that many practices. So, you know, the health department really taking initiative. I mean, a lot of times Vermont also does well with different health measures because it's a relatively small state and you can reach every practice relatively easily. But other than that, I don't know the specifics of why Rhode Island. I mean, I know there has been, I know that they are a high HPV immunization rate state, but not sure.
Thank you.
Are there any other questions before we continue? You need to hit #6 if so.
So this is Renee. Do you have any recommendations, just kind of thinking about, you know, your experience as someone who's kind of, I think, really far ahead of the curve? You know, I think every EHR is a little bit different. I mean, I think you were talking about, you know, just, I mean, the data pool. So, I mean, if folks don't necessarily have the EHR, you know, for some of us that are in systems, we didn't even have a choice over which EHR we have. Other folks, you know, have EHRs and it's, maybe there's newer and better versions, but just cost prohibitive. Is there anything around the health IT aspect in terms of getting to know your EHR, or do you have any recommendations to kind of help with the data pools that could more globally, you know, like agnostic to what EHR you have?
Yeah, sure. So every certified EHR has to have the ability to run quality metrics to support meaningful use. And some of these are in those CQMs. So if it's a certified by the ONC EHR, it has the capability. The question is, how do you get to the person who knows how to get to that? And you know, if you don't know, call support. If you're part of a health system, whoever your, you know, CMIO is, somebody knows how to get those reports from your systems. If you are sort of don't understand how to navigate the IT world, I am more than happy to take those questions one-off. I can at least help you know how to approach it through a systems level. But you start with, so if you don't know that person, just call support. Everybody's got a support Probably inside your EHR, there's a support button. A lot of systems have user listservs or health forms. If you don't know, ask your vendor if there is one. Get on it and say, hey, I'm doing a project. Does anyone else know how to do this? There are resources, but they have to give you some form of the measures that we're working on, because they have to report that, they have to have the capability. So it may be problematic getting to the people who know, but there should be the ability to get there.
Sue, this is Eve Kimball with All About Children. Asking about the population management software that's out there. Is there any advantage to those? Can you just do some comments about that?
So it really depends on the capability you have in your inherent system, and how much they do it themselves or partner with people who are aggregating data. And for our work for this project, and it was interesting, Amy alluded to this. If you affect change for a couple of charts and you affect the system of your office, even though you may not be able to measure the whole practice or every payer or every whatever, if you can measure something and work to improve that, there is likely spread for the whole population that you may not be able to see. Some people like me like to see that whole population, and then we get into a whole different argument about, who are my patients and who are they not. But any way that you can get at a population or subpopulation of data that has these elements is crucial for you being able to understand what your starting is as your baseline, and then look to see where are my gaps. And I would encourage everybody to not already start figuring out how you're going to fix this until you know what your rate is, and or at least do some work on following up on your hunches, right? Because sometimes you put data in front of you and you're like, oh, that's not the biggest problem I have. Here's the biggest problem I have. Let's tackle that first.
Hi, this is Amy. I just wanted to add for that it's not, it's not just the numbers. I mean, I think the way to not just be assuming, but to be, to be getting the data is with the more detailed chart reviews of at least a subset of your patients, so that you can see, these are the specifics. Because as I said, some people, I think a fair number of people in our project were surprised when they looked at the charts and saw what they saw by different things. But
in the QI world, we call that a root cause analysis, right? So like, here's my measure, here's what I pulled, and then it's looking deeper into this. Is this adolescent not had well visits for the last 4 years because they actually scheduled appointments and they never showed up? Do you have a no-show problem, right? Versus, someone in my front desk staff is supposed to be marking these patients as transferred, and I think I have all these active patients that are really not my patients. So if you don't take a couple of examples and follow them all the way down to the root cause of why is this, or wait a second, all of these, they're supposed to be making a recheck appointment on the way out, and it's not happening. You're not going to get that kind of really actionable information unless you start with your measurement and then look to the chart behind the measurement.
And just, to follow down that point, with the root cause analysis, that you keep asking why, if they weren't getting that appointment made before they left the office, okay, why did that happen? And keeping it, down to, you keep asking that over and over and over, getting more and more specific, and hopefully getting to more and more doable small things that you can change.
And don't be afraid to think outside the box, right? This is the cool, there are practices that got rid of their checkout. The MAs did the checkout in the room, including make the next appointment, because people go to the bathroom and sneak out the front door and don't ever check out. So, there's all kinds of different, if you decide that there's something that you discover that's just like, don't feel like you have to fit it in exactly the way you've done things all along. And the cool thing about involving staff in that is if you give them the challenge, there will be like, well, we always wanted to do it this way, but we were taught this is the way we do it in this practice. And some of my most innovative ideas have come from the people who have to really own the problem. The person who's responsible in my office for recalling patients and getting them in for well visits came to me and said, we don't have room in the schedule. What would you like us to do? And we said, well, let's add on some evening hours, a couple of hours a month. And then they said, we don't think that the evening hours is what they want. We're hearing from patients they'd rather have early morning appointments because it's easier to figure out how to get your kids to school late rather than try to figure out how to interrupt soccer practice and a million other things. And so we actually went back to patients and got a patient advisory, and some of you have them already, and or send up a survey monkey like, could we better meet your needs? And it totally changed the way we solved the problem when we involved the person who had to do the work and the family.
Great. Thank you, Dr. Presley, and thank you, Amy. So we just want to kind of wrap up today with just some next steps. As we talked about, this is, the first in a series, or actually the second, I guess, in a series of our quality improvement work. So we'd like folks to kind of look at all your payers, look at your pay for performance quality metrics, look at which one of your payers are actually giving you and remunerating you for your adolescent well visits and immunizations, and start to pull your data and start to think about where you stand. We also wanted to go over the calendar of events. So after today's webinar, we have our next webinar is going to be January 31st of the new year, same time. We'll be sending out information on that to talk about the specific projects that Dr. Presley alluded to, the immunization well visits, and pulling that data. And then we want all of you to save the date for April 27th out of the Penn Stater. I know our Western friends will be happy that we're out there. At the Penn Stater, we're going to do our QI Boot Camp, which is our all-day conference. We're very excited. We've already been lining up the agenda for that. Dave Kelly, the head of Medicaid, is going to be there, as well as some of our payers. Dr. Pill, we have a great day lined up, so I think you guys won't want to miss it. Just begin to think about it. I know people are starting to open calendars. Who on your team, your QI team, or in your office, you might want to be coming to that conference. This might be one where, someone in your office that's doing QI or billing or things like that. It might be, you might have a different team or some similar folks that come to this. So, and then just contact information for all of us. And really just want to say thank you for being with us today. And we certainly want to thank our presenters, Dr. Presley and Amy Wishner, for sharing their expertise. And please feel free, if you had a question or you think of something, just email Eileen and we will get back to you.
That's great. Thank you, Dr. Turchi. And I just want to remind everyone to take time to review Dr. Kresley's videos and the materials that she had that we sent in the reminder. There's lots of information that will help us along the way there. And I just also want to let everybody know that I'm going to be following up with all the MOC prep as I have that forwarded to myself. So we will definitely be in touch with everybody, but to please have on the calendar those days coming up in January and in April. All right, and we will be sending out, the CME credits as well. Please, as we stated, everyone complete the evaluation individually. So we just want to thank everyone for your time today, and we look forward to speaking with you in January. Thank you.
Thank you. Happy holidays.
Happy holidays.